Welcome, everyone, to our transplant medicine seminar hosted here by Lifebulb and sponsored by Veloxis Pharmaceuticals. So thank you very much to Veloxis. I'm Karin Hienberger. I'm the president of Lifebulb and also the chief medical officer of Patient Care America. I am joined here today by Dr. Crew, who is an associate professor of internal medicine at Columbia University Hospital. Really happy to have you here today.
Nice to be with you again.
We are here today to talk about the immune modulatory or immune suppressive medication that is needed to preserve those organs. And I'd like to start out by just asking Dr. Crew, what is that concept of transplantation and the role of immunology?
Sure. So, your body has evolved over years to protect yourself from outside things. For most of the time, these are pathogens, bacteria, viruses like COVID or influenza, fungal infections. And so your body has multiple different systems within that immune system, multiple different types of cells that are looking for things that are not soft, things that are different from you. Just like you develop inflammation with pneumonia to get rid of a virus, you can develop inflammation in an organ, like you said, if it's a pancreas or a kidney or a heart, and that kind of inflammation will end up damaging the transplant. Even though the transplant is human, there are a lot of differences between all of us, just like you have beautiful blonde hair and I don't have any hair. Your organs express different proteins than my organs, and my immune system would recognize yours as foreign. And if we don't give people medications, the cells in the immune system will start attacking the organ and will begin to experience rejection, and the creatinine will start going up in the setting of the kidney, or in people with a heart transplant, the ejection fraction, the muscle in the heart won't work as potent. So we frequently have to give really strong medications to keep the immune system from attacking the organ. And the amount of immunosuppression that we need actually depends on how far out you are after transplant. It turns out specifically with a kidney, for example, that if you take a kidney out of someone who's deceased, say they died in a car accident or something like that, and then you transport it for 12 hours out of the body, put it in someone new, you reperfuse it, you restore blood flow to that organ as it's trying to heal, it actually naturally attracts a bunch of different cells to it. That is an additional barrier for us to overcome at the beginning of a transplant. And so most of the rejections that we see actually are pretty early after transplant. At least rejections early after transplant are different from the ones that are further out. So about 2/3, maybe 3/4 of rejections happen within the first 6 months.
Question, because this is truly interesting. So what you're saying is that in that first moment of the surgical process and you place the organ into the recipient, there is a certain kind of rejection that could happen that is based on the organ's attraction of certain molecules and tissue types. So what is happening there in the beginning that is different than over time?
So at the very beginning of a transplant, when you reperfuse the organ, you re-expose it to blood, to oxygen, there's these things called oxygen-free radicals are released. Actually, the damaged cells, some of them break open and release their DNA. There are other things, they're called damage-associated molecular patterns, or DAMPs. And these things actually on their own trigger more cells to come into the transplant. Now, this, you mentioned like a different type of rejection. It generally is a different kind of inflammation because it's not what we would call allospecific. Well, the first cells that go in there don't recognize it as, oh, this is someone else's kidney. They are just recognizing damage signals that are associated with an organ not working right. And evolutionarily, that was something protective, because the most common reason the organs weren't working was because there was some virus infection or bacterial infection. And so it's what we call the innate immune system, parts of the cells that are just reacting to damage signals. They get attracted to the organ. The cells begin to infiltrate inside there, and a larger percentage of cells are passing through than normally would if the organ was healthy. But what can happen with kidney transplants is that some of those innate cells will begin to recognize the tissue as being foreign and will begin to proliferate and grow and actually lead to rejection. So the kind of inflammation that we see just related to damage from transporting a kidney from one person to another, the gene expression of the DNA there actually begins to change, and it begins to attract more cells. And so we see rejection rates for our deceased donor kidneys between 15 and 20% of the time, at least in our program. But for our live donor kidneys, our living donor kidney is being taken out of a healthy person in one operating room, transported within an hour to the other operating room right next door. They hook up all the vessels. We see rejection rates of only 8%, 6%. And so,
There must
yeah,
a difference if there is a certain time period between placing it in the new person versus there's less damage when it's a quick period between.
correct, exactly. And so then as you attract more cells, some of those cells are going to be specific against the kidney or whatever organ is put in there. So we do see slightly higher rejection rates early after the transplant. As the kidney heals, though, or as all these organs heal and those damaged associated molecular patterns, these damp signals go down, there are fewer cells going into the kidney. As fewer cells are damaged, there are also fewer proteins that are being processed and expressed and triggering other immune responses. And so the amount of cells that are active against the kidney begin to go down. And so the doses of the medicine actually can go down over time. So most of our patients are on the highest doses of medication for the first 3-4 months. We begin to taper them down, never completely off. People do need to be on medicine still forever outside of some special protocols. But then beyond the 1 year mark, people are pretty much on the amount of immunosuppression they're going to be on for the rest of their life.
This first rejection that you're talking about, which is more the damaged cells attracting, a protection from the immune system or by the immune system, is that handled by different drugs than the chronic immune suppression that is needed to essentially address the antibodies that have developed after the innate immune system has had its course?
We'll say that there's some debate about those early cells that come in and where there truly are the same kind of rejection as other rejections. Some people, particularly a physician in Canada named Phil Halloran, who's done a lot of work on the gene expression of the cells that are coming in to repair. And he has found that the gene expressions are different. And yet we do consistently see people who have had this damaged kidney, what we would call delayed graft function, meaning that the kidney was damaged. It wasn't working right at the beginning. It took a week or two for the kidney to wake up. But those cells do have higher rates of rejection going down. And so the kind of hypothesis is that those cells that are coming in, some of them actually, they come in a sort of non-specific way to just clean up damage, but some of them actually will naturally be specific to the organ and begin to proliferate and then trigger a kind of cellular rejection. And that kind of cellular rejection is the most common kind of rejection that we see after transplant. And it's handled with similar medications that we'll talk about later: tacrolimus, cyclosporin, mycophenolate, steroids, things like that are usually enough to control that kind of immune response.
It's very nice to clarify the early stage and the chronic stage, and also to emphasize that the chronic stage is chronic. There is no time currently with a kidney, maybe different with the liver, where you can totally taper out the medication, even though there are protocols involved, including, I think, at Columbia, where there are tolerance trials where that is being attempted. But let's start with the general treatment. Would you like to take us through what happens upon transplant?
Sure. So in the hospital, because rejection rates are higher early after the transplant, patients go into the operating room, and actually, while they're under anesthesia, they start their first medications through the IV. And so we give high doses of steroids, a medication called solumedrol. And then most patients in the United States, at least, will also get a different infusion of what's called induction therapy. And so induction therapy is more potent immunosuppression to suppress the immune system for the first couple weeks, months, even as long as a year. We can sometimes find changes in the immune system. And in the United States, that comes in 3 different kinds. There are some that block some receptors on some cells. It tends to be the version that's available in the United States is called basiliximab, and that blocks a receptor on some of the T cells and reduces rejection rate. It's not quite as potent as 2 other medications that we happen to use here. One is called thymoglobulin. Antibodies, what we call polyclonal. It binds to all sorts of different proteins that are available on lymphocytes being the medications that lead to most rejections. And then there's another medication out there called Campath-1H, which we've used on and off for a while, and many centers use effectively to prevent rejection. So those 2, thymoglobulin, Campath-1H, they're a little bit more potent. And as you increase potency, it's great. You reduce rejection rates. But unfortunately, you do begin to see slightly higher rates of virus infections, virus infection called CMV in particular. Some people have found increased rates of pneumonias, bacterial infections, things like that. And so in transplant, we're always trying to find the right benefit between medication that is too strong and is going to cause side effects like infections that maybe the patients can't tolerate versus medications that aren't strong enough and lead to too many rejections, because if you have too many rejections, then you're impairing graft function, you're doing biopsies, you are rehospitalizing people to treat rejections. And so I wish I could tell you exactly how much medication each individual patient needed, but we do our best.
I am really interested in that because I do think that in transplant medicine, we're not really that, well, maybe you don't agree, and I would love to hear that, the tailoring of the amount of drug for each person is somewhat blunt.
It is blunt. We really lack the diagnostic test to tell us how much each person needs. And it's also something that's not static. We could reduce the medications and follow something and say, oh, you're doing great, until you begin to expand some of those lymphocytes that were dormant. And then all of a sudden that test changes. And once the horse is out of the barn, it may be very difficult to get those things back under control.
How do you measure those lymphocytes that you're talking about during the process of transplantation?
Two of the medications I mentioned, the thymoglobulin and the Campath-1H, actually physically eliminate those from the body. Some centers, particularly dosing thymoglobulin is given day after day after day for usually 4, sometimes 5 doses. And so some centers will actually follow on a blood test every day how many lymphocytes are left in the body before they give the next dose to see if it's been suppressed enough, say a level under 25 cells. A normal lymphocyte count, or a T cell count specifically, would be around 400, 600, something like that. So if you get sufficiently low, maybe you don't need any more doses. For example, it's the same test that many providers use to follow HIV. We follow that in terms of dosing medications, responsive therapy, stuff like that. We sometimes use the same test in transplant patients getting thymoglobulin to confirm that the medication actually worked. So the one question is, how low are those lymphocytes? The second question is, if it's your first organ and you've never been exposed to other tissues, like through pregnancy or through blood transfusions, maybe those cells aren't really primed to attack organs. So maybe getting a count down to 25 matters for someone on their third organ, but doesn't matter on someone on their first organ. And so there's a lot of subtleties in measuring the lymphocyte count that don't actually fully capture prior exposure and risk of rejection.
So after Campath or ATG or thymoglobulin, the patient moves on to additional medication that is going to be used in a chronic manner. What options that we are now offering to our patients?
Sure. So then, and again, while they're in the hospital, they're starting on their maintenance immunosuppression, their chronic immunosuppression. And most patients are on 2 or 3 medications other than these IV infusions to keep the kidney or every other organ working. Now, in the United States, 25% of patients do not use steroids, but 75% of patients are maintained long-term on tapering doses of prednisone. It's no one's favorite drug, but it does happen to be effective as an immunosuppressant, and so it's still commonly used. The most common mainstay of immunosuppression in the United States is a medication called tacrolimus, which comes in different forms. Veloxis happens to make a form called Envarsus. Prograf was the original form. It's what's called a calcineurin inhibitor, and so it gets inside the lymphocyte. When the lymphocyte recognizes as something foreign, all these things start to happen inside of the cell. And so it blocks those cells inside that sort of signaling pathway inside of the lymphocyte to keep it from growing when it encounters foreign tissue. And cyclosporin came out around 82. Tacro was the mid-90s. Cyclosporin just revolutionized transplant because before we were experiencing graft failure rates of 40% in the first year, very high rejection rates, and then instantly cyclosporin came along. Rejection rates were cut in half, graft survival rates improved, and then it became a real option for patients. So this is, early 80s when not just kidney, but it allowed heart transplantation to become successful, beginning of lung transplantation, things like that. So anyway, so tacrolimus is a little bit more potent than cyclosporin in terms of reducing rejection rates. And then in addition to that, most people are on another medication that comes in the class of what's called an antimetabolite. Mofetil is a common one, which goes by the brand of Cellsup. There's another one, mycophenolic acid sodium, which is sold under the name of Myfortic. Both of them reduce the ability of lymphocytes to grow DNA. They can't grow DNA, they can't really replicate, and so it's another mechanism of reducing the lymphocyte's ability to attack foreign tissue.
Why does the antimetabolite preferentially or selectively address the lymphocytes?
Turns out that lymphocytes, when they're growing, the precursors to make the DNA, they have more than one enzyme, and it sort of preferentially affects that enzyme that lymphocytes use. Now, it's not 100% specific, and so cells that grow quickly tend to be sensitive to inhibition of DNA. The most common side effect of mycophenolate is GI toxicity. And so many of those patients undergo endoscopies, and when you do biopsies, many of those patients you'll find some inflammation, and you'll also find that what's called the crypts, the lining of the intestine, it's a little bit flatter than it should be because maybe those cells aren't growing back as fast as they should.
Colitis.
Correct. And so you can see changes in the colon are very common. Changes in the proximal small bowel and the duodenum are also very common. The other cell component that grows really fast is your blood cells. Even though it's sort of more specific for lymphocytes, other white blood cells, granulocytes can be affected, hemoglobin production can be affected, platelet count can be affected, not as much, but still it's very common for people to have some bone marrow toxicity related to these medications because they're not 100% specific for lymphocytes. And so later on, we'll talk about a medication called belatacept, and there are a couple new medications coming out that are similar that sort of block that pathway. Well, thank you very much.